intraoperative floppy iris syndrome. So it's a intraoperative floppy iris syndrome is characterized by billowing of a floppy iris, propensity for iris prolapse through surgical incisions, and progressive intraoperative meiosis during phacoemulsification. So the overall prevalence is around 1 to 12%, and it was originally described with tamsulosin, but there are several other risk factors like increasing age, hypertension, finasteride, AC inhibitors, and antihypertensive drugs. And the risk is more if the dilated pupillary diameter is less than 7 and the dilated pupil to limbal ratio is less than 0.6. So stopping tamsulosin does not prevent its occurrence. Now let's see what happens in IFIS. See this patient, you can see during phacoemulsification, the iris is floppy and the pupillary margin was coming to the phaco probe, and you can see the fluttering and floppiness of the iris because of the fluidics, and the iris was coming out through all the incisions, thigh ports and the clear corneal incisions. Now this patient was not on tamsulosin, so I didn't suspect iris. So phaco was done, and then during phaco there was progressive meiosis, and as you can see here, when sculpting, when the fluid was going under the iris got lifted up and there was fluttering and floppiness. And during this the pupil further came down, and then somehow I took out these nuclear pieces through the small pupil, and it's luckily the nucleus was not very hard, and so I could take out the nucleus, and in this case I coated the endothelium with viscose, so that because I was doing an antechamber phaco to protect the endothelium, and somehow there was no complications, and I could place a lens inside the bag. Now, so having seen these, how can we prevent these complications? So one is we should have a proper preoperative and surgical planning. So preoperatively I give atropine drops twice daily, 2 days prior to surgery. And preoperative and end-stage drops can reduce the incidence of intraoperative meiosis. And you should have dispersive OVDs, iris hooks and rings in case you need them. And before surgery I inject intracameral adrenaline. Now this patient was on tamsulosin. So after injecting dispersive OVD into the anterior chamber, so one thing is that you should take care not to pressurize the anterior chamber, don't overinflate the chamber, because the iris keeps coming out then. And then after putting dispersive OVD, that is, take care not to overinflate the chamber, the rhexis was done. This is NS3 plus cataract. You should have an adequate size rhexis. And then during hydrodissection, you can see that there's a tendency for the iris to prolapse through the clear corneal incision there. So and you can see the floppiness, and then the nucleus was nudged to take out the trapped fluid behind the nucleus, and the mobility was ensured. And see, as now I am proceeding with phaco with normal parameters. The bottle height is usual, the aspiration flow rate is usual. So see, you can see the fluttering and floppiness of iris. Now what I did is, I reduced the phaco parameters, that is aspiration flow and the bottle height. See, now the chamber became stable and the iris stopped fluttering and coming to the probe. So one important thing is you should operate under low phaco parameters, that is low IOP if it is active fluidics, or low bottle height and low aspiration flow rate. Then another thing is, when you are doing phaco, here you are doing in the slightly in the anterior plane, that is it should be in the supracapsular plane, and you should chop the nucleus into multiple small pieces so that it will be easy to emulsify, and carry emulsification in a slightly anterior plane, that is in the supracapsular plane. And during cortex removal also, you should take care to reduce the parameters, that is low aspiration flow, so that everything within the anterior chamber happens very slowly, so that the anterior chamber becomes stable and the iris also becomes stable. Now after phaco, a 3-piece foldable IOL is going inside the anterior chamber. I usually put them on the iris and then dilate into the anterior chamber. Now coming here, this patient was on tamsulosin. So I was expecting IFIS because the pupil was not dilating well. So I have decided to use Malugan ring in this case. So intracameral adrenaline was injected, but there was not much dilatation of the pupil. So then dispersive OVD is going in, and then I don't overinflate the chamber, and the side port should have a long intracorneal tunnel, and here the clear corneal incision is also having a long intracorneal tunnel so that it prevents the iris prolapse. Now I inject little gel under the iris so that I can place the ring easily, So it gets lifted up from the anterior capsule. So by injecting, you can see the two scrolls that is getting engaged initially, but the other two scrolls are not getting engaged. So I've placed them manually. Those are engaged against the iris border. The anterior chamber should not be shallow when you are using these rings. So it should be deep, at least normal. And then dissection should be very gentle. Don't keep on injecting fluid because it is that time that iris start creating problem. And then nucleus is emulsified. A routine phaco is done, and place a single piece hydrophobic acrylic lens inside the back. Now after that, I am slowly releasing the scrolls, and the hook was carefully placed on the iris, and little gel was injected, and it was taken out. Now at the end of this surgery, the pupil has come down almost back to the physiological position, here as you can see. Now this is the second case. Actually this patient had severe IFIS in the other eye, and the pupil was had moderate dilatation, but since he had severe IFIS in the other eye, I decided to use Malugan ring in the beginning itself, and the nucleus is very hard. It's around NS4, and here as you can see, the ring is giving a good adequate dilatation, and then the rexus is slightly larger because the cataract was little on the harder side. And you can see even after putting the hooks, the iris between the scrolls that is coming to the probe, and it is showing the floppiness. So then there was iris prolapse of the main tunnel, so the scroll came out. Then again I replaced it and completed phaco. As sir told, I had put trypan blue in the beginning, that's why it has gone behind and a little bluish tint is coming from the vitreous. And finally the iris hook was taken out mechanically, and the case was completed. Now in this case, I've used iris hooks. As sir told, you have to make the incision for putting iris hooks just inside the limbus, and it should not have a long tunnel, it should be very short, and fill the chamber with viscoelastic. It is difficult to place the first hook. Once you lift up the iris from the capsule, placing rest of the hooks are very easy, and only thing is you have to retract the sleeve adequately before hooking the iris, and then adjust the tension so that you get enough dilatation, and don't tighten it too much. And then rest of the things was done in the normal way. Phaco emulsification is carried out, again using low parameters. And here I am placing the lens over the iris, and then I am dialing it into the back. Now while taking out the hook, you have to retract the sleeve, and see the hook should be parallel to the iris while you are taking out, and the paracentesis, so that while taking out you don't damage your paracentesis and the iris margin. And actually after putting, there were few sphincter tears because I have tightened it too much, and it's not that physiological as in the case of Malugan. Now coming to the practical tips, few things. One is preoperative atropine and NSAID drops are useful in reducing the incidence of intraoperative miosis. And the side ports should have very small and should have a long intracorneal tunnel. And you should have a perfect phaco wound with the long clear corneal tunnels. And you should use dispersive OVD because the iris will behave better with that in the case of IFIS. And never overinflate the chamber because it is that time the iris starts coming out. And hydrodissection should be gentle with as little fluid as possible. And phaco should be done with low pressure, low aspiration flow parameters. And you can have a slightly anterior plane emulsification so that the fluid current doesn't go under the iris and lifts up and causes prolapse. And you should always use pupil expansion devices whenever it is needed. Thank you.